Thank you to the first panel. This is the second panel, and we'll start with Mr. Woodson. I'm going to have to run to another subcommittee hearing. I'll turn it over to Senator Gillibrand, and I'll be back as quickly as I can. But let's go ahead and get started, Mr. Woodson.
Chairman Graham, Ranking Member Gillibrand, and members of the committee, thank you for placing the issue of military health system reform high on your agenda for 2016. The military health system takes great pride in its performance in combat medicine over the last 14 years, with greater than 95% survival rates for those wounded in battle. Our ability to prevent disease through exceptional primary care and preventive medicine services produced equally historic outcomes in reduction of disease and non-battle injuries. The challenges we face in medicine and in national security, however, continue to evolve and require new approaches to be prepared for the future. We have undertaken a number of initiatives to strengthen the military health system in all facets of its responsibilities, and they have been organized around 6 principal lines of effort, which we have spoken about in previous testimony. I therefore was encouraged that last year's Military Compensation and Retirement Modernization Commission reviewed and supported many of the initiatives that we have already set in motion in the department. Let me briefly describe these efforts. First, we have modernized our management systems with an enterprise focus. We established a Defense Health Agency that Vice Admiral Bono leads. The agency is entrusted with providing common business processes and standards in support of the military departments and combatant commanders, an approach that provides greater operational efficiency and ensures joint solutions to our customers. We identified multi-service markets and developed 5-year business plans to promote common solutions and optimize the use of military treatment facilities while providing required care to beneficiaries in the purchased care sector. In addition, we acquired and are now preparing to deploy a new electronic health record using commercial off-the-shelf products. Together with the Surgeons General and Vice Admiral Bono, we have established an enterprise-wide dashboard to actively manage our performance in readiness, access to care, quality, safety, patient satisfaction, and costs. The Defense Health Agency achieved the milestone of full operating capability on 1 October 2015, and in its first 2 years saved over $700 million. Second, we're defining and delivering medical capabilities and manpower needed in the 21st century. With the services, the Department has embarked upon a thorough process to define essential medical capabilities and metrics to monitor readiness. Third, as a result of the modernization study, we have analyzed infrastructure needs and right-sized several military treatment facilities, as well as made adjustments to move skilled medical personnel to markets where MTFs can recapture care, they can maintain their skills, and reduce overall costs. Fourth line of effort is perhaps the main focus of today's discussion, and that is our plan for reforming TRICARE. We are appreciative of the input from beneficiaries and service organizations that in recent testimony have expressed support for TRICARE. The TRICARE benefit was named as the #1 health plan in the country for customer experience by Temkin in 2015, owing in no small part to the comprehensive coverage and low cost to our beneficiaries. And by the way, we jockeyed for that position since 2011 with Kaiser Permanente. But we also have heard loud and clear from our beneficiaries that access to care, access to both primary and specialty care needs attention, particularly in the MTFs. In response, we've implemented a number of access improvement initiatives last year to open up more appointments, resolve appointment issues on the first call. We are improving access to after-hour cares, particularly for child care, whether that is through evening and weekend clinics, the ability to email providers questions through secure messaging, the availability of 24/7 nurse advice line that is integrated with our appointing system, streamlining the referral process, and implementing urgent care demonstration program that Congress requested in last year's Defense Authorization Act. Our T-2017 contract will be awarded in 2016 and includes provisions that further improve the experience of care for our beneficiaries. The PB-17 proposal provides choice and incorporates feedback from our stakeholder groups. The fifth line of effort has been to expand strategic partnerships with civilian health organizations to enhance our ability to meet and exceed our responsibilities in readiness, quality, safety, and satisfaction. Partnerships with organizations such as the American College of Surgeons and the Institute for Healthcare Improvement are providing tangible benefits that offer us ways to sustain our trauma system, improve clinical quality, and achieve our goals as a high-reliability organization. Finally, the sixth line of effort is focused on global health engagement, where the Department is deeply engaged in national security threats posed by infectious disease and building bridges through health care around the world. We have contributed to the surveillance, prevention, diagnosis, and treatment strategies to combat well-known outbreaks to include Ebola and now Zika, as well as ongoing efforts to prevent other outbreaks from occurring. We entered 2016 confident that the reforms in the military health system and the health benefit can be further strengthened through a combination of legislative and operational reforms. I am grateful for this opportunity to be here today, and I look forward to your questions.
Chairman Graham, Ranking Member Gillibrand, and members of the subcommittee, thank you for the opportunity to appear here today. I am pleased to represent the Defense Health Agency and explain how the DHA is contributing to the modernization of the military health system. In November, I was honored to become the Defense Health Agency's second director. Only a month earlier, the agency had reached full operating capability after 2 years of collaborative work with the Army, Navy, Air Force medical leaders, and with the Joint Chiefs of Staff that established the concept of operations for many of the functions of the agency. Our responsibilities center on supporting the military departments and the combatant commanders in the execution of their missions. The Defense Health Agency was created in the recognition that most healthcare delivery is common across the Army, Navy, and Air Force. What we need, what we buy, what a best practice entails in both the clinical and administrative environments. The Defense Health Agency helps bring together common support functions into a new, enterprise-focused organizational structure. We are able to help Dr. Woodson and the Surgeons General see and manage across the MHS in a more unified way. One of the principal ways in which we deliver the support is through the operation of shared services. Critical enterprise support activities include TRICARE, pharmacy operations, health information technology, medical logistics, public health, medical R&D, education and training, health facilities, contracting, and budget resources management. In addition to the 10 shared services that have been implemented, the DHA has also brought in joint activities that had previously been distributed to the services that acted as executive agencies. These include the Armed Forces Health Surveillance Center, the Armed Forces Medical Examiner System, the DoD Medical Examination Review Board, the Defense Center of Excellence for Psychological Health and Traumatic Brain Injury, and the National Museum of Health and Medicine. The DHA offers value, however, to more than our COCOMs and services. We serve as a single point of contact for many intra-agency, interagency, and external industry matters, simplifying the process for our partners and outside colleagues to work with the Department of Defense in support of a number of imperatives, such as research, global health engagement, adoption of emerging technologies, healthcare interoperability, and more. The existence of the DHA has streamlined engagement with the Defense Logistics Agency, Defense Information Systems Agency, and other field agencies. External to the department, the DHA provides a single point of contact for operational matters within the VA, a number of agencies within HHS to include Centers for Medicare and Medicaid Services, the Food and Drug Administration, the Centers for Disease Control and Prevention, Public Health Service, and more. We have successfully collaborated with the Justice Department on the prosecution of healthcare fraud cases, most recently with highly suspect activities around compound medications. We work with Treasury, State, and the GSA on a number of critical functions that directly support our healthcare mission. I would like to focus on one shared service in particular, the operation of TRICARE, the military's health plan. TRICARE modernization is part of the MHS modernization plan that Dr. Woodson just outlined. We have a number of TRICARE initiatives already underway in 2016. Later this year, we will award the next round of TRICARE contracts, known as T2017, which is when healthcare will become operational under the new contracts. We are simplifying the contracts, reducing management overhead in both government and contractor headquarters by moving from 3 regions to 2 regions. We are expanding the means by which we manage the quality of our networks to ensure they meet the expectations for quality and safety that we expect for our beneficiaries, whether in the direct system or in a private sector network. We also will introduce innovative models for value-based purchasing in the coming year. My staff, in close collaboration with the services, is also crafting the contract amendments to permit TRICARE enrollees to use urgent care centers without pre-authorization. And our analytics team provide the department's civilian, military, and medical leadership at the headquarters and field level with the ability to assess the enterprise-wide performance of the military health system using agreed-upon joint measures for readiness, health, quality, safety, satisfaction, and cost. The DHA is now an integral and integrated part of the military health system. We are proud to contribute to the modernization of this system through a joint collaborative solution and responsible management approach. I am honored to represent the men and women of the Defense Health Agency, and I look forward to answering any questions you may have.
Chairman Graham, Ranking Member Gillibrand, and distinguished members of the subcommittee, thank you for this opportunity to provide the Army Medicine perspective on defense healthcare reform. It's an honor, first I'd like to say, to serve as the Army Surgeon General and Commanding General of the U.S. Army Medical Command. Since 1775, Army Medicine has supported our nation and our Army whenever and wherever needed. However, today I would like to focus on our more recent history. For the past 14 years, we have supported an all-volunteer force engaged across the globe and supporting the joint campaign fighting in Iraq and Afghanistan, and responding to national disasters and other contingencies, such as the U.S. government response to the Ebola outbreak in West Africa. We have accomplished this while continuing to attract, educate, and train the next generation of Army medicine. We are collecting what we have learned over the past 14 years and ensuring that we are using these lessons to inform our daily efforts and how we prepare for the future. Our readiness to serve when needed is my #1 priority. In assuring our readiness, Army medicine must maintain medical capabilities that are ready to deploy and support our warfighters. During the past 14 years of combat operations, we have achieved a survivability rate, as you heard Dr. Woodson mention, of 92%, the highest in the history of warfare, despite the changing tactics of our adversaries and the increasing severity of battle injuries. And we're not going to lose the knowledge and the best practices that helped us achieve this survivability rate. These advances in combat casualty care resulted from our integrated health services that span the continuum of care, from prevention to treatment of illness and injury, and to recovery and rehabilitation in both the garrison and the operational environments. We cannot, however, focus exclusively on sustainment of combat trauma, surgery, and burn capabilities. Our experience shows that the Army must be agile and adaptable, and therefore must maintain a broad range of medical capabilities to support the full range of military requirements. To that end, we see our medical centers, hospitals, and clinics as health and readiness platforms. They ensure we maintain trained and ready medical personnel by exposing them to a diverse and broad range of patients with a wide variety of illnesses and injuries. Our medical centers also serve as platforms for our Army graduate medical education programs. These programs are the primary means for transferring the knowledge from this generation of military providers to the next. While we focus on our readiness mission, we must also ensure we provide our soldiers, their families, and our retired population with access to high-quality health care that meets their needs and encourages health. Improving access to care is a priority for Army medicine, and I have directed actions to rapidly improve access to care. First, we will enable our beneficiaries to book an appointment up to 6 months in advance, and we've already piloted that at some of our installations. Womack Army Medical Center is one example. We will increase the number of available appointments by increasing the time our providers are available to see patients and reducing the number of unfilled appointments, and also working on the no-show rate, which leaves a large number of our appointments unfilled and unutilized. Additionally, we are opening 3 new community-based medical homes and will evaluate where after-hour or urgent care clinics are necessary. As part of the health services enterprise, we will also continue to expand our telehealth program. We are currently conducting a pilot to treat low acuity patients in the emergency department at Fort Campbell as one example. We are also expanding remote health monitoring programs and leaning forward to expand our telehealth to the home. I'd like to thank Dr. Woodson for recently signing the policy to help us expand that facility-to-home telehealth initiative. I understand reforms are necessary to ensure the long-term sustainability of TRICARE. However, reforms must not increase the financial burden on our active duty soldiers or their active duty family members, and must minimize any impact to our retired population. Reforms should encourage beneficiary use of our direct care system to ensure our medical military skills are maintained, and should also encourage healthy behaviors, as you've heard our colleagues mention previously. But reforms must not degrade our combat-tested system or readiness in an environment where we must remain rotationally focused and surge-ready, as the next large-scale deployment could be tomorrow. General Milley states that the Army's fundamental task is like no other. It is to win in the unforgiving crucible of ground combat. Now, Army medicine does not literally fight wars, I understand this. We are, however, a critical enabler to ensure our Army achieves this end. Our nation's mothers and fathers know that when their sons or daughters become ill or injured, we are there, we are ready, and this gives them the confidence to send them into harm's way if called. This is a truly sacred trust, and our readiness to support the warfighter can never, will never be in doubt. So I want to thank you all for your continued support to our soldiers and to military medicine, and I look forward to your questions. Thank you.
Chairman Graham, Ranking Member Gillibrand, and distinguished members of the committee, thank you for the opportunity to come before you today to discuss the future of the military health system. We fully support the committee's work to enhance the focus on value and delivery of the health benefit to those we serve, consisting of sustained good health, streamlined patient experience, readiness of the force we support, and the readiness of our medical force. Strong health systems must continuously improve. Changes to the Air Force performance management process implemented in 2015 as part of the Coordinated Action Plan following the Military Health System Review are producing continuous improvements in safety, quality, and timeliness of care. Recent evidence includes the Joint Commission recognition of our hospital at Joint Base Elmendorf-Richardson for outstanding performance on key quality measures. The Keesler Medical Center's top 10% ranking among all U.S. hospitals participating in HCAHPS measures of patient perspectives, and favorable system-wide performance against national benchmarks in perinatal outcomes, diabetes management, and well child care. We know our performance as a health system is integral to our readiness, and we remain committed to continual improvement. Today, we have 683 medical airmen deployed around the world, providing medical support to contingency operations, including the trauma team at Craig Joint Theater Hospital in Bagram, Afghanistan, mobile surgical teams at various sites, and aeromedical evacuation teams with critical care capability. Our success in support of deployed operations is inextricably linked to the care we provide in our hospitals, our clinics, and our many partner institutions. The bedrock of our readiness is the military hospital. Of the 76 Air Force military treatment facilities, only 13 today are hospitals. I would add that 30 years ago, in 1986, we had 73 hospitals. So over the past 30 years, the Air Force has closed and converted 60 hospitals. Our capability to meet combatant command requirements with deployable medical teams hinges primarily on our 8 largest hospitals. The broad scope of care we provide to retired military members, their families, and veterans is key to our readiness. The Air Force has a number of agreements with the VA under which we provide specialty care to veterans. As we consider changes to the military health system, we believe it is very important to facilitate retiree access to specialty care in military hospitals and provide tools enabling more agreements with the VA and other federal health systems. To ensure our readiness, we have evolved to a model in which Air Force surgeons and critical care specialists devote a portion of their time to provision of care in partner institutions, such as VA medical centers and Level 1 trauma centers, where more complex care and trauma are prevalent. I would offer as an example the medical group at Nellis Air Force Base in Las Vegas, where the surgeons on staff at Nellis, vascular surgeons, orthopedic surgeons, and general surgeons, do a significant portion of their cases in the VA Medical Center in Las Vegas, but also at the University Medical Center in downtown Las Vegas, which is the only level 1 trauma center for Las Vegas. This provides the needed balance of complex cases for a proficient deployable clinician. An additional key point pertains to primary care support for active duty families. Experience has shown that primary medical support to active duty families from our military treatment facilities enhances commanders' efforts to support families under stress and strengthens the resilience of families. As changes are considered, we strongly recommend sustaining care for active duty families in military treatment facilities. I thank the committee for its steadfast support and dedication to the welfare of the airmen, soldiers, sailors, Marines, their families, and our veterans. Thank you.
Ranking Member Gillibrand, distinguished members of the committee, it is my honor to represent the men and women of Navy medicine, 63,000 dedicated professionals who every day honor a trust in caring for those who have sacrificed to defend our freedom. We are grateful for your strong and unwavering support of our service members and their families. As you consider potential changes to the military health system, I thank you for that, but I would like to highlight important considerations that I believe are central to any discussions. Military readiness and combat support are our mission. Navy medicine protects, promotes, and restores the health of sailors and Marines around the world, at home and deployed, and in all warfare domains. We are equally privileged to care for their families. In an increasingly complex world, as our Navy and Marine Corps stands ready and engaged around the globe, Navy medicine stands there as well to protect and to care for them. As an agile, rapidly deployable medical force, this is what sets us apart from civilian health care. No civilian health care company in the world routinely leaves their families and home on a moment's notice to willingly go into harm's way to care for those in need. No healthcare company in the world daily puts their lives on the line in battle to defend and care for their patients, as the young Hospitalman Corpsman Second Class, who I was privileged to see awarded the Silver Star 2 weeks ago, did without thinking. No healthcare company in the world experiences the staff deployments and turnover we routinely experience and still delivers world-class care. And finally, no healthcare company in the world is daily and singularly focused on the combat readiness of its staff. And the proof is on the battlefield. Highest combat survival in recorded history. Wounded warriors are alive today who, in any previous conflict, would have died from their injuries. They are the testament to the effectiveness of the military health system because every one of them, from point of injury on the battlefield to advanced treatment in our medical centers, received their care from men and women who got their training, their experience, and their preparation in our military treatment facilities. Those facilities are the foundation of battlefield survival. And in my opinion, as a former commander of a deployed expeditionary combat medical facility, a robust military health system is critical to future battlefield survival. Unparalleled combat survival in our nation's longest conflict is proof that a robust military health system that also serves as our training and search platforms for our battlefield providers, from corpsman to physician, is essential to both combat survival and agility in rapidly supporting our deploying operational forces. These three facts are not in dispute. 1, we have the highest combat survival in recorded history. 2, many wounded warriors alive today would have otherwise died of their injuries in any previous conflict. 3, every wounded warrior received their care from injury on the battlefield to recovery in our medical centers exclusively by men and women who received their training, their clinical experience, and preparation in one of our military treatment facilities. This is a system that works and has proven itself time and again in the thousands of men and women alive today. It is also a system that is not perfect, and I appreciate your attention to this much-needed area of reform and improvement. The services are working hard to improve access, care continuity, convenience, and satisfaction with the care and benefit that we deliver in peacetime. We have made important strides in each of these areas while concurrently increasing enrollment, network recapture, staffing realignments, and other efforts to ensure we provide the clinical experience our staff needs to preserve skills, competencies, and ultimately combat survival in the next conflict. And it is more than just trauma. 70% of the evacuations in the most recent conflict were not trauma-related. Every single person on our team, every single person wearing a uniform in the Navy today maps to an operational platform, is assigned to an operational platform. We do not have people in uniform for peacetime care. All of them have necessary roles and responsibilities in the next conflict. More needs to be done, and none of us underestimates the effort required to improve our peacetime healthcare services. We are committed to continuing those necessary reforms which will improve our patients' experience and, most importantly, their health. However, we must do so without putting at risk the very system which has yielded such unprecedented survival. We will need your help in this effort, and for your tireless support, I thank you for helping us to ensure that those sailors and Marines who will stand the watch in the future will have the same or better survival than today's wounded warriors have had. In our hands is a sacred trust to do all in our power to return home safely America's sons and daughters who have sacrificed to defend our freedom. I thank you for helping us to honor that trust today and tomorrow.
Thank you all. I'm very grateful for your testimony. I'm very grateful for your service, and I appreciate this discussion today. I'd like to start with Dr. Woodson. Senator Tillis and I are both very interested in this issue of comprehensive autism care. I'm pleased that the Defense Agency initiated the comprehensive autism care demonstration in 2014, and I'm very interested in seeing the outcomes of this program. However, I'm concerned to hear that DHA intends to lower reimbursement rates for providers of ABA therapy for autism. I'm most concerned that providers of ABA therapy will no longer be able to accept TRICARE because the reimbursement rates are too low. Are you at all concerned about the impact changing reimbursement rates will have on children's access to ABA therapy? And what steps have you taken to ensure that access to these services will not be adversely affected by changes in reimbursement rates? And finally, why not wait until the demonstration program is complete so that the results are not skewed by a rate change?
Senator, thank you for that very important question, and let me just assure you that I am, and as we all are, very committed to special needs children, and that's been a major emphasis in terms of many of our reform activities. In regards to the rate changes were actually delayed 1.5 years. We did an internal study on rates because there were no established national rates, and of course, part of our statutes require us to pay Medicare rates. So we set an amount, and we studied it for a few years, did an internal review. And then we were about to make rate changes, and in fact, we heard from stakeholder groups, including Autism Speaks and others, convened repetitive conferences to engage them, and then commissioned 2 outside studies that confirmed that we were overpaying. And I'd be happy to share with the details of these studies with you. Finally, just to ensure that, in fact, we won't negatively impact services, we reviewed network adequacy almost on a monthly basis, and certainly very frequently. So we'll be monitoring this situation very closely. And should we find, in fact, in any locality that it's been adversely affected, we will make rapid changes. The final point in regards to this is that we put in a safety valve in that we're not going to reduce rates right away completely. It's a stepwise progression over a number of years so that we can ensure that we don't lose providers.
Well, I have some specific concerns with regard to the studies and the methodologies because I don't think they are reflective of the cost. And so I'd like to request some follow-up information specifically on that and further consideration, because I think it's inadequate. The reason why Autism Speaks spoke so forcefully against the proposed rate changes is because they're the experts on treating children with autism. And so I think your study is misleading in its outcomes. So I'll follow up with specific questions, but I'd like this to be readdressed because I'm very concerned that there will be very negative consequences for patients. My second question is about innovation and different ideas about how to innovate healthcare for our service members. When I was in Fort Drum earlier this month in upstate New York, I was impressed with their approach to healthcare. There, they have a clinic on the base that provides basic primary care and service to members and their families, for their members. But their members and families also go off base for their specialty care. The clinics and providers in the community, by virtue of serving the military population, have an excellent understanding of the needs of our men and women in uniform and their families. And this is along the lines of questions that Senator McCain asked to the last panel. So has DHA looked to Fort Drum as a model for providing health care, and how can we better leverage community health care options in serving the military community? Anyone can take the question.
Senator, I'll share with you a pilot we have in San Diego right now. San Diego County, 1 out of every 5 residents is eligible for military health care. That's 250,000 people. Of those, 662 are what we call high utilizers. These are folks that use anywhere from 15 to 30 times as much health care as anyone else in the county. We've partnered with County Public Health to aggressively manage them as a community-based effort. These are folks who the car will break down, and so they'll call 911 to get a ride to the ER to get medications. Care will be fragmented in a variety of different urgent care centers. And so by partnering with County Public Health and bringing to bear county services as well as military provider services and a medical home approach, but in a community-based format, we have improved their health, cut their health care costs in the first year for 250 of them by over $4 million, in the second year by $12 million, and dramatically cut by over 60% their hospitalizations. So that's one issue that we're in the process of exporting across Navy medicine.
Thank you.
Thank you, Senator Gillibrand. Regarding the innovation of healthcare in the Fort Drum model, that is a phenomenal model for that area. But we've noticed that it might not fit in all of our demographic areas, and the sizes of our MTFs vary from location to location, and that may not be reproducible. But there are additional things that we're doing, such as at Fort Leonard Wood, Missouri, the innovation of using telehealth, where they actually have a virtual ICU set up, where they have a telehealth arrangement with an ICU in the state of Arkansas to help them with that. So these are leveraging technology, using telehealth, using other types of partnerships in order to achieve some of those same ends. But I agree that for the Fort Drum community, that model that they have works very well. Thanks.
Senator, I mentioned in my statement that the Air Force has 13 hospitals. That is actually below our operational requirement for deployable medical teams. And so we've had to use some innovative concepts in order to meet our operational requirements. So we have about 2,500 Air Force medical personnel embedded in other services hospitals, and that's one way we're doing this. But the other way we're doing it is we have embedded surgical staff into private sector hospitals in Omaha, Nebraska, Tampa, Florida, Phoenix, Arizona, Oklahoma City, and in Birmingham, Alabama. And they're providing beneficiary care in those hospitals. I would say, though, that while that model has been successful for us to some extent, I don't think we can go too heavily in that direction because, as I said in my statement, the military hospital remains the bedrock of our readiness because that provides readiness to the entire deployable team, the enlisted, the nursing staff. The embedded operations in private sector platforms tends to benefit the provider staff, but not so much the nursing staff.
Mm-hmm. Ma'am, there's some other areas, too, where we've all been doing some innovative work, and this is in our enhanced multi-service markets. And each of the services has this, where we have about 45% of our resources and 45% of our patients where they need care. What's innovative about that is that between the services, we're able to level set some of our resources, and depending on where the demand is for care, one of the hospitals can send personnel to other hospitals within that same market where the demand is. And just as an example, here in the National Capital Region, when we were looking at the demand for physical therapy services, we were able to understand with a baseline assessment of where the demand for physical therapy consults were coming from, referrals. And by using some of the assets within a couple of the bedded facilities, we're able to send physical therapists to those clinics where there was a high referral rate. And by doing that, we were able to get care closer to the patient in a more timely manner, and it also decreased some of the demand for specialty care down road. So this is something that all of the services have with the enhanced multi-service markets.
Question now. Thank you very much.
Thank you, Mr. Chair. Mr. Woodson, rather than go back through what Senator Gillibrand brought up on the ABA treatment, I would like to join with Senator Gillibrand in some follow-up. I think the key there has to do with timing, and the most important thing is to understand the profoundly important value of this treatment for not only the child that may be receiving the treatment, but also the health and quality of life for the active duty personnel, the military personnel, and the spouses. Admiral Faison, I want to start with you and then probably ask the other surgeons general to chime in because I think you're making a very important point about the unique nature of this health system. But I also want to get to military hospitals, clinics produce inpatient, outpatient workload costs about 50% higher than what it would cost if the services were purchased in the private sector. Can you give me some help in trying to rationalize what the real gap is? Because there's obviously some structural costs based on the unique nature of what you're doing, but give me some sort of sense of what you believe may be an attainable goal or some sort of narrowing of the gap, or is that gap right and proper?
Yes, sir, absolutely. So if you look at our costs break down really into two large buckets, and there are smaller buckets, but the two large buckets, of course, are facility costs of maintaining bedded facilities, and those are important as we get casualties back, the Walter Reeds of the world and places like that.
So there's an unused capacity that you may not find in comparable private healthcare settings.
Absolutely. If you look at the civilian sector, they are running bed occupancies of 90+%. We don't do that because our beds are in reserve for contingency operations. The others are personnel costs. We staff to operational plans of the combatant commanders. I don't staff to peacetime care. So I have, in some places, more staff in uniform than necessary for peacetime demand. But that's because of an operational war requirement. We try and put those personnel in places where we can keep their skills current. And as you've heard, sir, from the other surgeons generals, when we can't do that, then we do out-service rotations at civilian centers and places like that.
Is there I'm sorry to cut you off.
Sir.
I just got a couple of questions. I want to
That's
make
all
sure
right.
I get to at least one more. But is there a good sort of breakdown or something that you all can provide us that really gives that to us in an empirical way? Because if we make decisions about going back and saying that we've narrowed the gap, that it's no longer 50%, if that's the right number, then we have to understand the trade-offs that we have in terms of capacity and what you're preparing to deal with. And I think that would be very helpful to get back to this committee as we go through and identify maybe opportunities where there is some safety. You in your opening statement said you're not perfect. I want to go find out where those imperfections are and spend the bulk of our time on this committee fixing those rather than going down a path where if we look at the data, we may agree that it's a structural cost that's the cost of doing business and the unique nature of your business. General, did you have a comment?
Yes, sir. I think one thing that's always a challenge when you talk about differentiating the cost of readiness versus the cost of providing care is that, as I said in my statement, the two are really inextricably intertwined. And so there is a lot of work we do that's operationally driven that is actually clinical in nature. And so if you look at our primary care operations, for example, things like medical evaluation boards, annual preventive health assessments, post-deployment health assessments, all of these things consume a significant amount of our primary care bandwidth. So it's very challenging to try to look at perhaps the cost of providing care to enrollees to our clinics and cleanly cleave and separate the cost of readiness versus just the cost of providing care. So that's one of the traditional challenges we've always had with answering this sort of question, is that the two really are intertwined very significantly.
Yeah, I think the key is to try and normalize it in some way that people can understand it, again, so that we set the priority on the things that we should improve, rather than look at things from a purely numerical basis that on the surface may look like an opportunity to drive improvement, but the consequences could be just the opposite of what we want to accomplish on this committee, which is to work with you and improve. Mr. Woodson, the TRICARE legislative proposal didn't contain, I don't believe, any recommended improvements for Guard and Reserve communities. Well, what's in the offing there? What can we expect?
Thank you very much for that question, because that set of proposals really requires some additional studies, because I think there are several courses of action depending on what type of reservist we're talking about. So let me just give you some examples to crystallize. On the one hand, of course, we initiated TRICARE Reserve Select to fill a gap in what we thought was medical readiness at the height of the war. The consequence of that was that the reservist and family would have to switch insurance programs when they came on active duty. So there is the possibility, frankly, of offering, of course, TRICARE Reserve Select to a larger population, or including it in employer-based options, which might be reasonable. There is the possibility, as the Commission talked about, providing a basic allowance for health coverage when they come on active duty, and we need to sort that out. And then there are some other hybrid options that are out there. The issue with reservists is really about not forcing them to change providers when they come on active duty, and so there are different solutions, and we need to work those out and study those a little bit more.
Thank you. Thank you, Mr. Chair.
Senator Blumenthal.
Thanks, Mr. Chair. As you may recall, Dr. Woodson and other members of the panel, in the 2016 National Defense Authorization Act, I advocated for a uniform formulary for improved transition from DoD care to the VA as service members transition out of active service. This measure was successfully passed, and now we're in an implementation stage. This joint formulary, I think, is critical to the quality of care, and in fact relates to a variety of related medical issues that may arise when there is a lack of sufficient transition in prescription drugs and other health care. What is the status of the implementation of the joint formulary from the DoD perspective?
So I think there's been much progress, certainly in the areas of mental health medications, pain medications, and some of those other critical medications for conditions in which a gap would create a great deal of problems. They've been mapped significantly to about the 96% level, so that we have a single formulary. And I know there's just a little bit more work that needs to be done on that, but there's been significant progress on that front.
On the issue of prescription drugs, particularly painkillers and opioids, is there an ongoing danger in the military, as frankly there is in the civilian world, of overprescription and over-reliance on painkillers?
Well, there is. That's something that needs to be addressed not only nationally but within the military health system. But what I would say is that I think in that regard we're a little bit ahead of the curve, and the reason being is that for a lot of different reasons there's been a lot of focus on the use of pain medication, and so we've developed more comprehensive strategies in terms of clinical practice guidelines. We have courses that providers must take in terms of pain management. We've invested in research and integration of alternative methods for pain control. And so this has been part of a comprehensive set of programs, I think, that we could even make available to some civilian healthcare systems.
On the issue of mental health care, has there been progress there, do you think?
I think there has been progress, but, you know, mental health care is really, the more we study it, the more we try and refine it, the more we find out about it. And if I could break this down into a couple of different issues, is that oftentimes dealing with mental health care, it's more than just delivering mental health care. It's about delivering social services and family supports, and that's one issue. The other issue about mental health care is that we always have this issue about whether or not we have enough providers, but really what we need is a comprehensive new strategy for how we employ our mental health specialists in a rational way to deliver care. So, you know, we never will have enough psychiatrists, we'll never have enough pediatric psychiatrists, but if we utilize them to do screening, then we make their time less available for treating complex problems. So what we need to do right now is work on a more rational approach to how we employ, let's say, certified mental health counselors, psychologists, licensed psychological nurses, licensed social workers in a continuum of care that allows us to address all the needs more comprehensively, because I'm not sure we'll ever generate enough mental health providers.
That's a strategy that you say has to be developed or is being developed?
I think we are working on that. So, you know, the previous panel talked about the issue of embedding mental health care in primary care practices. We've been doing that for years. We've been embedding mental health care technicians and practitioners in line units. We have already rolled out some of that more comprehensive strategy, but still, I think we need to array the different types of mental health professionals in a better way to take care of many different problems.
As you know, active duty members of the military who may suffer emotional or mental diseases, some of them emanating from combat, post-traumatic stress, and traumatic brain injury, sometimes are given bad conduct discharges or less than honorable discharges, bad paper, and then, through a tragic irony, are deprived of medical care to treat the very injury that causes their discharge under less than honorable conditions. And I have sought to have those discharges reviewed. And in fact, two secretaries of defense, beginning with Chuck Hagel and most recently Ashton Carter, have committed to change the policies of the boards of correction review within each of the services. Has your input been sought on that issue? Because there are medical issues involved in those reviews.
So the short answer, Senator, is yes. And let me, first of all, thank you for your advocacy in this area. And of course, for the last 2 years, we have actually reached out to individuals who have been discharged with so-called bad paper to let them know that their cases will be reviewed. But to your last part about your question, we have given mental health professionals to these boards of review so that their cases can be accurately reviewed.
Thank you. My time has expired. These subjects are tremendously important, and I want to thank all of the panel members for your hard work, all of the hard work done by the men and women under your commands, and thank you for being here today. Thank you.
Thank you. I'll be looks like the last questioner here. How many casualties have we suffered in Iraq and Afghanistan? Not fatalities, but injuries. How many people have been wounded, requiring admission to a hospital?
Senator.
Anybody know?
Yeah, Senator, it depends on how you actually calculate those numbers, whether or not you include disease and non-battle injuries.
It doesn't matter, as long as you're in Iraq and Afghanistan, you have to go
So
to
it's
the
over
hospital.
100,000.
Okay. Admiral Faison, can you imagine a military healthcare system that did not have a military hospital?
Sir, no, I can't.
Okay, because the bed space you have is not designed for everyday activity, it's designed for wartime contingencies, is that right?
That's correct.
Most of these beds are empty, not because, during peacetime, simply because they're built to deal with wartime contingencies.
Sir, if I may, those beds are not empty. We work very closely with the managed care support contractor to get care back into our facilities for skills and competencies.
So what percentage of your beds are occupied?
In general, we try and maintain a bed occupancy of 80% or higher.
What about the Air Force?
Sir, we have a lower bed occupancy than that. We are more in the 50, sometimes up to 70% range.
What about the Army?
Sir, it varies. Some of our large MTFs, Fort Bragg, in San Antonio, have a higher occupancy rate. Some of our smaller facilities are, have a low daily patient census, and those are the ones that we're actually looking at to, to realign, capability there.
Okay, so here's my point. If we're going to reform something, we need to understand what we're trying to accomplish here. If you had civilian hospital administrators over military medical facilities, would that create a problem?
Sir, military hospitals are just like any other military command. I personally would not put a civilian in charge of a ship. In order to
That's
have a
what you'd
culture-
be doing, wouldn't it?
Exactly, yes, sir.
So a hospital is a military entity, and the military command structure can't be substituted.
Yes, sir, because the good order and discipline carries over to the battlefield.
Right.
And it starts in the hospital.
Okay, General West, at the end of the day, what would happen if we opened up competition to all these military facilities? Where would the military doc go?
So that's a very good question,
I
because,
mean, what would they do?
sir, again, when you're...
Like a dentist? Like if it's cheaper to pull teeth downtown, which it may be,
Yes, sir.
like how do our dentists stay proficient in pulling teeth?
Yes, sir, exactly. And when you say open to competition, sir, I think we are not in the same business as, for profit. I mean, we're here, no one appears to want to be in competition for our deployed
So you treat
environment.
family members of active duty personnel, all of you, right?
Yes,
And that
sir.
keeps your skill level up. It's
Yes,
good
Senator,
for
it does.
retention, good for recruitment.
Yes, Senator.
Does every member of the military have to go through an annual physical? The answer is yes.
sir.
Yes, sir.
So isn't that primary care, General Edger?
Yes, sir. It
So
is.
that's a primary care activity that's related to readiness.
Yes, sir.
And those same doctors will be treating kids with a cold.
Yes, sir. I would add that what we do when we provide care in our MTFs, we are ultimately a mission support activity. And so we are actually supporting commanders who are conducting missions. So in the Air Force, it's global mobility, it's the nuclear mission, it's RPA operations, cyber ops. And so by taking care of the airman and the family in our military treatment facility, we're actually helping that commander take care of that family. And
So when you say that a military hospital costs 50% more to operate than a civilian counterpart, is that a fair comparison given the unique nature of military medicine?
No, I think it's an apples and oranges kind of comparison, sir, because
Do you agree with me you could make things more efficient?
absolutely.
And that's the goal, right?
Yes, sir.
Do you all agree with me that the people under your command have done historic work on behalf of the nation?
Absolutely.
I want to tell everybody on this committee that in this war, which has been going on for 14 years now, there are people alive today that would not be alive in any other war. And y'all guys are the unsung heroes of this war as far as I'm concerned. I've been to forward deployed areas where people come in who've been blown up. And it's amazing how you can put people back together again. And that whole network from Landstuhl to Walter Reed is just literally priceless, but it needs to be more efficient. Any last comments?
Senator, if I may make one comment in connection with making sure everyone understands that the maintenance of a military health system is essential to the defense of this nation. The point I would make and give you an example is that the MTFs are part of the medical force generating platform. And today in this country, there are 1,000 fewer graduate medical education spots than there are American medical graduates. If we were to eliminate the military treatment facilities in the military health system, we couldn't generate enough doctors, and I would say also nurses, but doctors to come on active duty. There just aren't enough training slots in this country. So we must preserve this generating platform, and we must preserve the graduate medical education program.
On not a happy note, I think TRICARE, as it's designed, is really antiquated. I wouldn't give it a B. I'm really going to be hard on y'all guys to come up with reforms, not just premium increases. We're going to look at TRICARE and turn it upside down and make it more transparent and make it more accountable, because we are basically using civilian networks when it comes to retirees and their families. So with that said, this has been a great hearing. Thank you all for your service, and we'll stay in touch. Hearing's adjourned.